since then, there have been some expansions. Presently, just over a quarter of the U.S. population is covered by one of the SEER registries. There's a new expansion that is not available through SEER Medicare yet just because of the timing, that will add 3 more states as well as greater representation of American Indians. So the SEER programs, as you can see, are progressively working to make sure that population representation and the diversity of the U.S. population are represented in the registries. But the registries are selected in part, largely on their ability to conduct high-quality cancer surveillance as well as to contribute to the population representativeness. So that combination is how the SEER has systematically expanded. This shows the present SEER registries. So if you were to order SEER Medicare data, these are the registries you would get. You will see there are several city registries, such as Seattle and Detroit, as well as Atlanta. There was an expansion in 1988 that added Los Angeles, San Jose, and Georgia, the rest of Georgia. And then in 2000, a further expansion that included the rest of California, Louisiana, Kentucky, and New Jersey. So we have very solid representation nationally, geographically, and demographically as well. There will be, the new expansion has added some states. We've added New York, Wisconsin, the Seattle registry is larger, Idaho, and so on, as well as more Cherokee Nation, for example. So you can see this progressive change. I point this out to you for 2 reasons. One, to help you understand the strength and the excitement that we have over working with SEER, but also so that when we come to questions about design, that you're aware that the registries have changed and your study design may need to take registry changes into account depending on what you choose to do and over what period of time. When we look at the SEER registry, so this is comparing cases diagnosed in 2010 with the 2010 census. What we'll see is that the SEER areas represent a diverse population, but at the blue bars, the SEER areas, the gray bars, the census, but we do see that there's still an overrepresentation of white people over other, is particularly Black. American Indian, while it may be representative, is very small and often too small to be able to do in-depth studies. So we're very excited about the 2018 expansion. The SEER registries are more urban concentrated than rural, and so we need to take that into account when we're doing inference and talking about representativeness. And again, the addition of some rural states will be helpful with the new expansion. We do have about what we'd expect for representativeness by gender, so we don't see any differences there. And so then understanding how the cases are identified by the registries. The registries use 2 methods. They use active and passive case finding. So the active case finding is notification from facilities who are required to review of source documents such as pathology reports. Passive would include other sources of information that might be received. It is important to notice that the SEER program relies heavily on facilities such as hospitals. And so one place where the SEER registries worry, and we agree, is when treatment and diagnosis is provided only in physician offices. And that's because that reporting might be less complete. So if you're thinking of a situation such as simple skin cancer, where it's often treated largely in physicians' offices, the registries may be less complete than you would like, and we would definitely want to consider whether we're seeing consistent information between SEER and Medicare and how to understand that. The cases are abstracted by trained professionals working for either a hospital or a registry. And this is important. They use a consistent process involving agreed-upon established rules. As a user, I can tell you very clearly that understanding the rules and occasionally taking time to look them up can be very helpful. So we will see a code and often say, I wonder what that means. But because these are consistent established rules, it means there are established code books. And we have sources so we can look them up and say, now I understand how this is used and how it compares to something else that sounds really similar, and I can understand the patterns that I'm seeing. So I encourage you all to make sure that you take the time to find your code books and to know where they are and at least look them over so you understand how the abstractors view the medical records. Because, of course, medical records are rarely consistent, even within a same facility, but certainly nationally. So the abstractors have the challenge of taking very inconsistent information and making it consistent. So the rule books and the abstraction manuals are an incredible resource. The data collected by the SEER registries fall into 4 categories. Demographic information, so about the people who are diagnosed with cancer. Information about the cancer itself, how it was identified, and details about the tumor. And we will go into those more later. There's information about the treatment and information about survival. And those are the very large categories of information that the SEER registries collect. SEER registries also the demographic residents at diagnosis. These are population-based registries, so one of the first steps that the registries do is confirm that this person actually is part of the registry catchment area. They collect gender or sex, age at diagnosis, year and place of birth, race or Hispanic origin, and marital status. A couple of these variables are not ones we routinely are able to get. Marital status, for example, is not a variable we are able to routinely obtain from other places, so many people find it quite interesting and an opportunity to be able to use it. The place of birth information is available. I think there always are questions about it because, of course, the abstractors don't go out and seek information that isn't there. So if the information isn't in a chart, they won't have it. And so one of the things that you need to think about when considering information that's obtained by SEER is this something that we would expect to be reliably in medical records? And to this extent, the quality of the medical record affects the quality of the data. The information about the cancer includes when and how it was diagnosed. So date of diagnosis, only month and year are released. Day of diagnosis is not released. We will talk about that more later on this morning. They also include information on method of diagnostic confirmation. Was it a clinical diagnosis?
The dual one, right?
Confirmed.
That will more match, okay? Easily, because this is more questions.
I think somebody needs to mute. We also have information about who reported the case to SEER, which category, not a person, but was it reported by a hospital? Was it reported by a nursing home? Did we get it from a death certificate or autopsy? And this information, again, we often use to determine, to help us get some insight and to determine how likely we are that this is accurate information. The SEER registry provides us with this information so that we can make the decision about who we want to include in our study. And then we also understand the sequence of cancers. Is this their first cancer, in which case the sequence number is actually 00, so the first and only? Was it their first of multiple cancers, or was it somewhere else? Was it their second or third cancer? This is important as we look at treatment because clinicians will make different treatment decisions depending on somebody's history. I'm going to take this opportunity to point out that there are some cancers where people can have multiple primaries. Breast is one, colon is another, and there are others where people can have multiple independent tumors that would be distinguished from being a recurrence. So as you think about that and make a decision about sequence number, take that into account. Likewise, if somebody is first diagnosed with in situ disease, for example, DCIS, which is in situ disease of the breast, and then later is diagnosed with invasive, they should have two records, one for their in situ diagnosis and one for their invasive diagnosis. In that case, we might not interpret that sequence number in exactly the same way as we would if someone were, for example, first diagnosed with breast cancer and then diagnosed with lung cancer or brain cancer or something else. The tumor information is very, very important and very useful. So we know the cancer type, we know the stage at diagnosis, we know the histology. Increasingly, we know tumor markers. So, for example, for breast cancer, estrogen receptor, progesterone receptor, and HER2 status are now available. We know lymph node testing and positivity. So we can distinguish between people who have no positive nodes, but in fact none were tested, from people who have no positive nodes but had 20 tested. That may change how we view the quality of their workup, but it also may change our understanding of the treatment patterns. We know tumor grade, we know size, and we know extent of disease or spread. The exact details of all of these will have changed over time with a definite trend toward increasing information, and also they will vary from tumor to tumor. So just because you look up kidney cancer and you can't find full detail across all of these things, the detail you want, does not mean that if you look up gastric cancer, you won't find more detail. So my big lesson here, and again from experience, is that whenever I look at a new tumor, I take the time to actually dig into these variables, and I've often been surprised at the level of detail and the number of variables that are available for me to work with. We also have basic information about the first course of treatment. First course of treatment, and this is an important definition, and I really want to highlight that it's important that you remember this, tape it to your wall, memorize it. The first course is defined as all methods of treatment recorded in the treatment plan and administered to the patient before disease progression or recurrence. So, as we will talk about, in some cases we end up with mismatches between SEER and Medicare, but if we understand what is included and we can think clinically, how long would this take, it sometimes makes things easier. SEER collects more information, and I do want to emphasize this, than is released as part of the SEER Medicare linkage. And this has to do with confidentiality, with quality, with consistency. They release, though, information, categories about surgery, and information about radiation therapy. And this is covered in quite a bit of detail in segment 4 later on this morning. SEER doesn't routinely collect or doesn't routinely release detailed information about all treatments, information about chemotherapy, information about treatment beyond the first course. So if the first chemotherapy didn't work and they had a second chemotherapy, SEER does not routinely release that. SEER does not routinely release cancer recurrence information or the exact timing. How many days from diagnosis to receipt of chemotherapy is not something that you will routinely find from SEER. I talked earlier about the importance of the manuals. Here are some websites. The SEER website itself, seer.cancer.gov, is important. There are documentations for the SEER data. There's training information. There are coding manuals, and there's a comparative staging manual. The other thing that can work is using your favorite web browser and typing in SEER, or sometimes I'll use SEER Cancer because SEER sometimes comes up with seers, or people who are willing to predict your future. But again, these are widely available and from the registries themselves as well as from the NCI. The Medicare program now is an equally complex and interesting and valuable program for researchers. Medicare, as you all know, is a federal health insurance plan available to qualifying elders, age 65 and older, and select disabled adults. So this is the population that is covered by the Medicare program. The Medicare program covers for most people as an entitlement hospital care, limited skilled nursing facility care, and hospice. And this is sometimes called Part A. About 98% of elders have Part A, and this is an entitlement, which means if you qualify for Medicare, you get this coverage. They also have 2 levels of optional coverage. The first level is called Part B, and that covers outpatient care, meaning care that is provided in a facility setting for people who don't reside there. So, for example, emergency rooms, day surgery in a hospital where you go in the morning, leave at the end of the day. It also covers physician and provider care and home health care. And this, again, is called Part B, and about 94% of elders enroll in Part B. And then there's another optional coverage, which is Part D, which provides prescription medication coverage. Part D, as some of you may know, began in 2006 as a benefit. SEER Medicare releases Part D data starting in 2007. And the reason that they made that decision is because the 2006 Part D data had some problems. They were not as comprehensive, and there were concerns about completeness that were resolved by the 2007 release. And this decision of not releasing 2006 is quite common, and most people who use Part D data opt not to use the 2006. And as we said, most people have Part A and Part B, and fewer people have Part C. So if you notice in this graph, Part A is the blue column, 98.6% have it. Part B is the green column, and Part D is the gold column. You'll also notice there are 2 rows. One is called fee-for-service, and one is called managed care. Medicare also has 2 ways of processing and coordinating claims. The fee-for-service program, sometimes called Original Medicare, involves, and I still think it's backwards, it should really say service for fees. In other words, providers provide a service. A hospital provides a hospitalization, and then once they provide it, they are paid for that. They give a service, they get fees back. The managed care plans, Medicare contracts with plans, and the plans are responsible for providing all care and coordinating those benefits. This is about 1/3 of all Part A enrollees are in managed care, and about 2/3 are in fee-for-service. The challenge, and we will talk about this repeatedly, is managed care plans do not release their claims. So with managed care, we know they're in managed care, and we can see the SEER side, but we cannot see the Medicare details. So we will be talking about this repeatedly throughout the course, about how to handle that in your data and the implications of different decisions. I point out also that Part D enrollment is much more common in managed care than it is in the fee-for-service program. Typically, the Part D is bundled into a managed care program, and with Part D, it's a different decision. So keep this in mind when you're deciding what to do. So broadly, the Medicare data include 2 types of information. They include enrollment data, so who is in the program, because if you're not enrolled in Medicare, then we have no expectations of seeing the claims. And then we have information from bills submitted by providers and processed by Medicare, so we know what Medicare paid for or what people asked to be paid for those Medicare beneficiaries. So the way it works in the fee-for-service is that whenever a Medicare enrollee receives health care, a bill is sent to the Medicare program to be paid. The bill will contain information that will help the bill be paid, but it's honestly almost exactly the same information we want. Who provided the care? When was the care provided, so we get exact dates? Why the care was provided, so a diagnosis. What care was provided, so was there a procedure? What was done? Was it an office visit? Was it a surgery? Was it a biopsy? And it also contains information about how much was paid for the care. And so those are the big categories of elements that we look for. we'll be covering costs in much more detail in segment 5. They're an opportunity, but are also can be very tricky. So if you're interested in costs of care or payments, please make sure that you attend segment 5. The data are organized based on bill type. So they're not necessarily arranged in a way that's intuitive for most researchers. So there are 7 claims-based service files. There's a file called the MedPAR, which includes the hospital and skilled nursing facility claims. There's the outpatient file, and that's non-inpatient facility claims. So it's largely hospital outpatient departments plus a few more. There's the NCH file, and that's what SEER Medicare calls it. If you've used Medicare data, it's often called the carrier file. There's the home health agency file. There's a hospice file. There's a DME, or durable medical equipment file, and so that will contain durable medical equipment that wasn't provided by a physician. And there's a pharmacy file. So you can see that, you can see already, and we'll talk about it more, that you will often have to look across several files to find a category of care or a type of service, because these are organized not by what happened, but by where it happened and who was paid for it. The money in Medicare, and as I said, we will cover this more later, but at a very high level, the fields in the Medicare claims files are divided into, I would say, 2 groups. The charges, which are what the provider, the hospital, the clinic, the physician, asked to be paid. Sometimes they ask for what they know they will get, and sometimes they ask for more. The charges are there, and we also know the payments. We know what they were paid or were approved to be paid. So we know, for example, that the hospital might be approved to be paid up to $10,000, but we will also see that there was a copayment that the patient was responsible for. So those are the 2 big categories of money in the Medicare program. There are some details of the Medicare program that I think make them particularly useful for studies, particularly longitudinal studies of cancer care. So first of all, they contain all claims regardless of where somebody is. So while the SEER registries are population-based, based on where they live at time of diagnosis, the Medicare data will continue to follow them. So if somebody lived in Iowa, was diagnosed with a lung cancer in Iowa, decided, I hope there's nobody from Iowa on here, that they were tired of the winters and they were going to move to Arizona, we would see the cancer diagnosed in Iowa, but we would also see all of their claims, including those from when they lived in Iowa, from when they moved to Arizona, and even if they went back to Iowa for summers, we would still see those claims. So the claims follow the person and aren't going to, so we've got a population base combined with a person-based analysis, ability to analyze. The Medicare program also will have fee-for-service care provided from enrollment until death. So that means we can look both at what condition or what care somebody received prior to diagnosis, as well as care they received after diagnosis or after first course of treatment. We have a better sense, and we'll be talking about this, about comorbidity, about how patients manage multiple chronic conditions simultaneously. So this again makes sure that we have a much more comprehensive view of things than we might otherwise. And that allows us, by using dates, to really understand what is going on and what conditions a person is juggling. There are some things that Medicare data do not contain, and these are important to remember. First of all, the reason a test was done is not included, and the results of the test are not included. So we cannot know, was this test done in response to some clinical sign or symptom, or was it a routine follow-up? We do not have test results. We do not have, for example, PSA test for prostate cancer. And sometimes, very importantly, we don't have pathology, so Medicare won't provide histology, but they also don't provide surgical margins. So we cannot tell if a tumor was completely resected or incompletely resected. We only know there was a resection. In some cases, that information would be very important to try to categorize and distinguish cases. There are behavioral risk factors that could be really, really useful that we rarely get. And I want to note here that there are codes for every single one of these things I'm going to mention, but it's really important to remember that just because it can be coded doesn't mean it will be. And so it's really important not to overinterpret these items and to do some checks to say, does this pattern make sense? But some that are not available we want to be very careful with. One is obesity. So many of the surgeons that I work with want to ask questions like, do surgeons do different things for obese patients and for non-obese patients? We cannot know that. Smoking is important for those of us who study smoking-related cancers. This can be frustrating. Or when they want to distinguish between somebody, for example, lung cancer among smokers and lung cancer among non-smokers. Smoking will be coded sometimes, and I personally believe that if the smoking is coded, you can assume the person smoked. But if the smoking is not coded, I am not completely sure that I believe that person was a non-smoker. So that's the challenge. Family history isn't coded, and alcohol use, among other things. So if you want to use a behavioral risk factor as a stratification variable or an explanatory variable, you need to think very carefully about whether it's going to give you the information you need. Other thing that isn't routinely found in the data is related to underdiagnosed conditions. So if something isn't diagnosed in a chart, it almost never shows up in a bill, which means we don't have it to work with. And the two biggest examples of that for me are dementia and osteoporosis. The presence of a dementia claim, we can be pretty confident that somebody thinks the person has dementia. But the absence of a dementia claim in no way should be interpreted as the person is cognitively intact. Likewise, osteoporosis, depression, there are a number of conditions that are underdiagnosed that well may be present. So if you're looking for those either as risk factors or as outcomes, take the time to consider how likely it is that somebody with that condition would actually have their condition showing up in a medical record. So then, but what can you find? And what you can find is really exciting and provides a lot of opportunity. You can get pre-diagnosis medical conditions that might influence treatment, so comorbidities. We can see diagnostic services such as ultrasounds, mammography, CTs. We can find detailed data about the surgery, what type of surgery it was done. We find other treatment. We will see the chemotherapy claim. So as I said earlier, SEER doesn't routinely release information about chemotherapy, but Medicare pays for it, which means using the Medicare data, you can understand chemotherapy. They provide information about the providers, whether it was a teaching hospital, bed size, some information about volume, get ambulance services. We know consults, not just oncology. We can find rehospitalization rates, the use of rehabilitation services, other care that comes at the same time. So one thing we will often see is during the sort of what we call the peri-diagnostic period, right around the time that somebody is getting worked up for their cancer and getting prepped for surgery, often other conditions will be found as well. And so we will often see cardiac testing, diabetes monitoring, and so on. We will also see treatment received after the completion of cancer treatment and payments for all of these. So you can see that although there are things that we cannot find, there are an awful lot of really important and really interesting things that we can. And so the dance that we need to use and that we will be talking about is how you find the opportunity and how you make sure that this opportunity matches your research question. I want to point out now that the Medicare data has got a tricky structure. And that's important because it means that you need to spend a little bit of time understanding your data. This is not a typical rectangular file. So for each person, we will have a PEDSF, which, and don't ask me what the acronym is, patient something file. And it will have the summary data, it'll have their demographics, it will have, for each cancer, the cancer type, the stage, the month and year of diagnosis, and so on. Each person will have multiple MedPAR records, that's multiple hospitalizations. Each hospitalization is a single record. So in this, patient A might have 2 hospitalizations or might have more. Each hospitalization is a single record that's in a rectangular structure. They will also have multiple records, for example, from the outpatient file. And the outpatient, the carrier, the hospice, the DME are all divided up into multiple segments. So each patient will have a claim. For each claim a patient has, the claim will be divided up by services. So an outpatient record for patient A might be divided up into 2 or 3 records, one for each of their services that they received. So you can see we have an enrollment record, 1 per person. We have hospitalizations, 1 record per hospitalization. And we have other claims records, which are going to be divided up into 1 per service. So what we often have to do is roll our outpatient records up to a claim level and then roll them up again to a person level as we are defining our variables. So the bottom line about the Medicare data is that the Medicare data are a rich source of information about cancer care and outcomes in the elderly. They are complex, and it's really important to take your time to think about it because you can spend an awful lot of time misunderstanding codes and being confused by things. If you remember, though, that the Medicare is an insurance company and that the organization of what they pay and how they pay is actually defined by the insurance function, and that is the perspective from which the data are collected. I personally have found that by keeping that in mind, I have been able to make sense and to understand what I'm seeing and why I'm seeing it. There are resources, and as with the SEER data, it's really important with the Medicare data that you take the time when you see things that don't make sense, to look into it. Medicare and You is actually a great information about the program. It's written for enrollees, so it's in plain English, but it's very clear and very helpful. The Medicare.gov website has a tremendous, almost overwhelming amount of information. I also encourage you to go to resdac.org. ResDac is a Research Data Assistance Center. It's funded by CMS to provide technical assistance for users of Medicare and Medicaid data. And there are a lot of documents and links and pointers to information about the Medicare program on that website. So then, putting it all together, what the SEER Medicare does, and the vision of why it was created, is combining information about incident cancers and their detailed tumor information with detailed information about treatments before and after cancer diagnosis, allows people to measure treatments and outcomes for clinically defined groups of cancer patients. So linking the SEER Medicare data together, the way it is done is personal identifiers for cancer patients are matched against the CMS's, Center for Medicare and Medicaid Services, master enrollment file. From that, their unique Medicare number is found. That number is sometimes called the HIC, and that HIC is used to extract claims for the people in SEER who are found to be Medicare beneficiaries. CMS sends these files to IMS, which is NCI's programming contractor, and IMS creates the analytic file. They remove the unique Medicare number and overwrite it with their SEER case number. So from this, again, we start with the SEER registries, we match them to CMS, we use the unique Medicare ID to collect the claims, but the unique Medicare ID is never released as part of the SEER Medicare data. The registries send NCI all of their cases for the linkage. The match rates are exceptional, I think. The most recent linkage had a match rate of 95.7% of the people aged 65 and older in the Medicare data. So if you remember, our estimate is that about 98% of people who are in this age range are part of Medicare. So this is an exceptional match rate with complex data and opportunities for mismatches all around. So again, I am constantly impressed when I see these numbers. And I'm not just saying that because Lindsay is on the call. There is variation across registries between about 91% and 99.2%. That involves a number of things, including variation across populations in how high their Medicare enrollment is, and perhaps information about quality of data that is found in the medical records. When we look at the cancers that are in there, between the period 2004 and 2013, there were 1.1 million people who were found unique people who were found in the data with a cancer. The breast cancer is about 12.7% of the data. 5.2% had bladder cancer, 10.5% colon cancer, 15% lung cancer, 16% prostate cancer, and so on. So you can see these end up being incredibly large numbers, and this is, if used appropriately, it can be an incredible advantage for asking questions and asking detailed questions and allowing us to focus on subgroups where normally they would be hard to understand. So thinking about what is included in the SEER Medicare data. SEER Medicare data includes 100% of the people in the SEER data who are found to be in Medicare. They have the ability, if you want to cut the population the other way, they also include a non-cancer control sample. And what that is a 5% sample of Medicare-eligible people, and they take the cancer cases and flag the ones who are part of the 5% population sample. So if you want to focus on cancer cases, you can do that, but if you say, no, I want to cut the other way and I want to understand risk factors for cancer, you can actually use the 5% sample that would combine non-cancer, your cancer, and other cancer cases and work it. So this, again, is additional flexibility that provides opportunities that aren't typically available. And we will talk about this more in the next segment. Sometimes people will call me up and they'll express concern because they found a cancer diagnosis in the control population and they're worried that maybe they don't understand the data right. And so it's important to recognize that there will always be people in the non-cancer population that have cancer diagnoses. And there are a number of reasons for these, and ultimately they provide insight that goes in both directions. You may also find cancer cases where you can't find any cancer claims. And in some of it is that the person, so going with the first, a non-cancer case may have a cancer diagnosis because the person may have been diagnosed with the cancer prior to moving to the area. In particular, I sometimes worry about people, snowbirds as we call them, who move back and forth. So if somebody's a resident in Iowa, let's say, and they're in Florida for the winter and they're diagnosed with a cancer, depending on the communication and care patterns, Iowa may not know about it. It's not that Iowa's not doing their best, it's that nobody from Florida told them and the records didn't move it up. So those people would show up, would look like they were non-cancer cases, but in fact, they do have a cancer, it just wasn't diagnosed in the area, so the registry didn't pick it up. There will be some cases that the registry misses. It may be somebody where their hospital didn't report it. It may be that there was a mistake in how the record number or name was transcribed so nobody could find it. And then we also have to recognize that there can be misdiagnosis in claims. Although technically claims should not include rule-out diagnoses, they sometimes do. So sometimes we will see mammograms coded as breast cancer. The reality is the diagnosis should be rule-out breast cancer, but often it's coded with a cancer diagnosis, a definitive diagnosis, when in fact there's no basis for one. So in those cases, the mistake will be in the claims. So when you're looking at your control populations, it's important to recognize that you will see cancer diagnoses there, and you'll need to spend time trying to decide how to interpret it. The converse, which is not on this slide, is will there ever be cases who have no diagnoses? And the answer there is very much yes. It could be somebody who, in addition to their Medicare, also has private insurance, and the private insurance paid for it. It could be somebody who goes to the VA, and all of their care is coordinated through the VA, and it doesn't return back. And it also could be a mismatch. There will be linkage matches where the wrong records are combined. What you will see as we go forward is that these are all incredibly rare in the range of 1% to 2%. So it's really important not to get stuck on the 1% to 2% problems, but really look at the 95% and then just do checks and sensitivity analyses to make sure you're interpreting things correctly. When you're looking at people, so earlier we talked about sort of the complex structure of files and so on. What I want to make sure you understand is that every person has a 10-digit ID known as a reg case or SEER ID that will be used across files consistently. So every single record for a particular person will have the exact same SEER ID. The first 2 digits of that ID reflect the registry number, and then the rest of it is a unique number. Controls will have similarly structured IDs where the first 2 digits will reflect the population that they come from, and the rest of the digits are unique numbers that will not be found linked to another person. When we think about the SEER Medicare data combined, we've got the enrollment files, the PEDSEF, which is the enrollment and cancer data. We've got a file called SumDenom, which is data for non-cancer controls. We have the utilization files that I talked about earlier, the MedPAR, the carrier file, the hospital outpatient file, hospice, home health, durable medical equipment, and prescription drug. And then there are other useful information, other files that you may choose to pull in. There's a hospital file. There's a file called the CCW flag file, and those are chronic condition flags that we will be talking about later on this morning. There also are data from other linkages that can be pulled in. There's MDS, which stands for Minimum Data Set, which is nursing home quality, and there's OASIS, which is home health care quality. So those can all be pulled in as needed and as they support your study design. And the SEER data included in the SEER Medicare data are in what's called the PEDSEF file. Here's my acronym, Patient Entitlement and Diagnosis Summary File. I want to point out that this is not in the same format as the SEER Public Access format. So if you're used to that file, this file is rearranged and you will need to take time to understand how it's similar and how it's different. But this is an individual level file, so each person has up to 10 incident cancer diagnoses per person. PEDSEF has flags that talk about Medicare enrollment and HMO eligibility. Those will be important to subset cases. They also are linked to socioeconomic data from the census at the zip code or census tract level. So this is what is included in the PEDSEF. Sometimes people get confused about the data and what they can do, so I want to review that quickly. So often what happens is we want to either look at the effect of a policy or we need to understand the impact of a policy change on what we are doing. So, for example, the linkage year 2017, so we would say I want the 2017 data, was actually released in 2018. The incident cases were from the years 2000, the newest incident cases were from 2014 and 15 and had claims through 2016. So what's happened sometimes is somebody will call me up and say, there's a new treatment that just came online in 2016 and I want to look at it with the 2017 data. because it sounds like that should work. But in fact, we'll often say, well, when would it actually have been covered by Medicare, and are you sure that you will be able to see it if the incident cases aren't from that year? So just keep this in mind. I always have to sort of look at this table myself and try to figure out when I can do it, and I sometimes have had to say, I love the idea, I need to do it, but I'm going to have to wait until the next linkage when everything lines up. And the reason for some of these lags is we have to allow the SEER registries time to identify cases and abstract the data. They need to be submitted to the NCI, linked with Medicare, and the data files need to be created. And all of those pieces take steps. If you actually think about all of the steps that happen, the fact that incident cases from 2015 and their claims are released in 2018 is pretty amazing. But it does mean you're going to have to stop and think about it and decide whether the timing works for your particular question. So as a bit of a pitch, just remember the strengths of using the SEER Medicare data is, first of all, the large number of cases, currently about 1.8 million people age 65 and older. They include longitudinal measures of health care from the time of Medicare coverage through death or through censoring. They span most clinical areas where health care is delivered. They represent a diversity of geographic areas across the U.S. So one of the things that allows us to do is to make sure that this isn't just a local phenomenon. They're population-based, so often we worry with single institution studies, which are often academic, is this just what academic institutions do, or is just this what the practice pattern is in Omaha, or is this in fact a broader phenomenon we're looking at? They include data on co-occurring conditions as well as conditions that were present before or after diagnosis. And we have the opportunity for a cancer-free control population. So in some cases, when we're trying to look at the long-term consequences of cancer care, we really want to compare them to people who wouldn't have had cancer at all, and this allows us to do it. There are some limitations of these data, and these are important limitations to keep in mind as you're balancing whether or not these are the right data and whether or not the limitations outweigh the strengths. First of all, the people under age 65 include the Social Security Administration categorized disabled people. This isn't all people with disabilities. This is people who the Social Security Administration has said are permanently disabled. And then there always is the data lag that we've got to keep in mind. There are non-covered services, so there are things the Medicare program does not cover, and those will not be in the data. Over time, the Medicare program has certainly expanded their preventive services, but there are things, cosmetic surgery not for reconstruction, for example, that will not be in the data. So if those things matter to you, it's important that you keep that in mind. Care not covered by the Medicare program, for example, from the VA or the Indian Health Service, will not be in these data. If you've got a population that you think is going to be a heavy VA using population, this might not be the right data set for you. And then if you remember managed care, so people who are in managed care, the only data we will find for them is their Part D data. This is not a clinical database. We don't know the reasons for tests. So people will often say, well, the only justifiable reason for this test is whatever. But in fact, we don't know that for sure. We don't know the exact reason for the test. We don't know the results of the test. We cannot tell if treatment was offered but not received because somebody turned it down or because of a scheduling problem. And symptoms and behaviors are inconsistently reported. The other piece, and this matters in some situations, is these are observational data. So these treatments are not randomly assigned. So if you care about random assignment, you're going to have to look into things such as an instrumental variable approach or other matching or other statistical approaches to approximate randomization. And it may be hard to control for unobserved variation. And then, which gets me to the final point, which is you don't know what you don't know. There are often things going on that we can't see and that you have to infer by comparing groups and saying, if I'm right, would this be the pattern I saw? The data are tricky. And if you remember from earlier, most people have more than one of each type of Medicare record in a calendar year. Many events result in multiple separate bills. Many of the bills are divided into sub-records, so that managing the data flow, this one-to-many, to-many structure, takes time, and it's important, particularly if you're counting things. So if you're trying to figure out how many x-rays did somebody have, understanding the structure and making sure you manage it correctly is really important. Understanding Medicare payment policy may be needed to understand what you're seeing, and ultimately you're going to need to create rules to translate bills. So there is no variable that says, were they diagnosed by ultrasound? You're going to have to create that variable. But I also want to point out some work that's been done by our group that could have only been done based on SEER Medicare data. We found higher rates of hip fracture after radiation therapy for women with cervical and rectal cancer and for men with prostate cancer. That needed population-based, needed large numbers. We also found higher rates of rectal cancer for men receiving radiation therapy for prostate cancer. We found a reduction in androgen deprivation therapy for non-indicated use after payment reduction, but no change in use for indicated conditions. So again, these are all things that we found with these data that we would not have been able to find without. So you notice it's a mix of treatment outcomes, of studying payment policy, of understanding treatment patterns, and these are all, amazing opportunities that are possible with these data. So for this reason, I'm delighted that you're all here to learn about it, and hopefully we can make your use of the SEER Medicare data a little easier. And we now have time for questions, and I understand that there have been some popping up. I see them on my screen a little bit.
So what I can do, we'll just take a few minutes here. I'll read the question, and Beth can kind of provide her insight into each. I think one of the first questions were, how were some of the states selected for inclusion in the registries?
The states applied to be part of the registries, and they applied and they made the case that they were capable of meeting the SEER standards, that they had population-based reach, and that they had an organizational structure. And they also said they were willing to have their data shared as part of the SEER consortium.
Okay. A second question is, if someone has multiple cancers, but their age of diagnosis for their first cancer may have been prior to Medicare diagnosis, would that individual still be included in the data?
And I apologize for not being clear here. For each cancer, there will be a series of variables. So for cancer 1, and again for cancer 2, and again for cancer 3, we will know the cancer type, the year of diagnosis, the age of diagnosis, the stage, the histology, the tumor size, the nodes. So those are repeated up to 10 times. So for each cancer, we will know. And that also means we can tell, so for example, what was the timing between the diagnosis of cancer 1 and cancer 2. So when we were looking at the study of second cancers, we sort of said, well, what are the different mechanisms that second cancers can happen, and how long would it take for a treatment-related second cancer to occur? And then we could use the timing between the diagnosis of cancer 1 and cancer 2 to categorize it, whether we thought it was treatment-related or not.
Okay, another question has to do with just the availability of the data, and you had touched on this, but maybe to re-highlight. If someone was diagnosed in a SEER registry, but they travel outside of the area to receive their treatment, would they still appear in the data?
So if somebody lived in a SEER registry and they were diagnosed in the SEER registry, so their first diagnostic workup happened in a SEER registry, or often the SEER registries have strong relationships with adjacent hospitals. So sometimes there can be border crossing. So somebody lives on right near the border between a SEER state and another state, and in fact the closest large town would be across the river or across the state border. They will have arrangements with those hospitals to do it. So using a Minnesota example, if somebody lives in the southwest corner of Minnesota, they may go to Sioux Falls, South Dakota for their cancer care because that's in fact the largest hospital that's nearby. And the Minnesota Cancer Registry has very strong relationships with Sioux Falls to make sure that the South Dakota hospital lets the Minnesota hospital know about these cancer diagnoses. And all of the cancer registries have similar arrangements, and for this reason.
There's also a number of questions about prognostic factors such as ER and PR status or other tumor markers. Are those available in the data, and where would we find them?
So, as I said, the tumor markers will vary from tumor to tumor. For example, with estrogen receptor status, there are, I think now 5 levels. So it's estrogen receptor positive, borderline, negative, not tested, unknown. There are a series that for prostate cancer, the Gleason scores are categorized in ways, and you may or may not like how it's categorized or what data are available, but the record layouts will have detailed information about what information is there and what values are possible. But it's really going to depend tumor by tumor, but those would all be in the PEDSEF file.
And many of them appear in site-specific factors, which it may not be an intuitive place to look, but that would be one of the places, apart from having a separate variable, where you might look for that. Okay. Another question that we've had, there seems to be a few questions around the linked SEER Medicare data versus the unlinked SEER Medicare, the unlinked SEER public use files, and whether or not those are the same data.
And the answer is that for the people 65 and older, they are the same people. There will be different variables that are released in each, and for different programmatic and scientific reasons. The structure of the files is different, so you can't merge the SEER public use data with the SEER Medicare data. Those IDs will not line up. And so sometimes we've got studies that we will use the public use data because it allows for something we want to do that the SEER Medicare wouldn't, and often it's the reverse. So they're similar, they're based on exactly the same cases, they have different case IDs, so you can't combine them, and you really are going to have to, for your tumor that you're interested in, and for your period of time, look them over and decide which one is the right source for you.
They do also have separate request processes that we'll be talking about later today. Okay, you introduced the concept of managed care. Why is this important, and how do we know when a patient is lost to managed care?
So managed care, as we said, is important because people who receive their Medicare benefits through managed care will not have claims in the claim files other than for medications, for Part D, and for hospice. Those are the only 2 exceptions. And so it's important to me because I want to make sure I remove them because I wouldn't want to mistakenly classify them as not treated. So we can distinguish then between people where we can't see the treatments they got and we can see the treatments they got and they didn't get it. And so that's why managed care is important. In the PEDSEF files, there are they call them HMO in the files, but there are HMO enrollment flags that can be used, and we'll be talking about that in the next segment and about how to use them. But this is the reason, because it's such an important factor. We will talk about this repeatedly. It's a mistake that sometimes people make because they don't understand the consequences of including people with managed care in their analysis. But again, there are flags in the PEDSEF and in the SUM denom that will allow you to identify these people so that you can make a decision about whether to include them or not.
Thank you. All right, we have a number of other questions that are very treatment or cohort specific. So we'll do a number of things. Hopefully a number of your questions will be answered throughout the day as we cover a variety of other additional topics. However, if your questions are not answered, we are working to find a mechanism to answer these questions and get them posted after the webinar. So don't worry, we will get your questions answered. It may just be a question of timing.